45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare and community wellness. We are continuously growing, learning and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. we make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international markets. For the past 2 decades, we have subsidiaries in Russia and South Africa, and we have a strong foothold in the USA, CIS and MENA regions. Our CSR initiatives cover core economic functions of accessible education, affordable healthcare, and community wellness. We are continuously growing, learning, and evolving. All this is us. While our look has changed, our values remain. Our new identity has a simple, solid look that is open to possibilities. It reflects the way we think and conduct ourselves. We are JB, good people for good health. Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicine
So, ma'am, it's 3, 2, 1, 0. We are live now.
Good evening to all. I am Dr. Komal Mandavkar from medical team JB Pharma. Welcome you all on the today's Lead HF program in collaboration with JB Pharma, an academic initiative. As the last week, the ESC HF Congress concluded in Lisbon between 11th to 14th May. We are fortunate enough that we have all the national experts today with us who are going to present and share their expert insights on the topic of best of ESC HF Congress highlights, and also they are going to focus on the choosing the right ARNI, which is one of the important pillar of heart failure management. To begin with, the agenda of today's meeting. First, there is a context setting of the program by our esteemed moderator, Dr. Tiny Nair sir. Then Dr. Subhash Chandra sir is going to talk on best of ESC HF 2024 Congress, followed by Dr. Pramod K. sir will talk on the choosing the right ARNI in heart failure. And after that, there is a panel discussions with all the national expert faculties. It's a privilege to introduce our today's faculties. Our esteemed moderator, sir, needs no introductions. We have Dr. Tiny Nair sir, the head Department of Cardiology, PRS Hospital, Trivandrum. Our esteemed speaker, Dr. Subhash Chandra sir, a very senior Senior Cardiologist, Chairman and Head Department of Cardiology, BLK Center for Cardiac Sciences, BLK Super Specialty Hospital, New Delhi. Dr. Pramod Kumar Kesar, he is a Senior Interventional Cardiologist from Yashoda Hospital, Hyderabad. Our expert panelists today we have on board Dr. Dilip Kumar sir, a Senior Consultant Interventional Cardiologist, Electrophysiologist, Chief Academic Coordinator at Medica Super Specialty Hospital, Kolkata. Dr. Prashant Advani sir is a Senior Consultant Preventive and Clinical Cardiologist Director, Advani Heart and Metabolic Center, Raipur. And Dr. Satish Balan sir, a Senior Consultant Nephrologist, KIMS Hospital, Trivandrum, Dr. Nair Hospital, Kollam. Welcome all the expert esteemed faculties. Now I request Dr. Tiny Nair sir to set the context for the meeting. Sir, please.
Good evening and thank you, Dr. Komal, for that nice introduction. Basically the lead program is where we learn together. I would say it is not just that the experts talk between them, but we, each one of us, learn from this experience and take home a lot of information. Now, I think today we are discussing in the next 1 hour a very important topic, right? Heart failure. Last decade, we used to talk about MIs, we used to talk about strokes, we used to talk about vascular events. Today, we are in heart failure. We realize that's a huge problem. In fact, we are fortunate that last decade has shown enormous progress in drug therapy, right? To an extent where devices are taking a back seat. Okay, we have the 4 pillars, we have the ARNI, we have the SGLT inhibitors, the MRA, the beta blockers, and they together has produced an enormous change in the entire scenario of heart failure outcome. But, here is the but. And that is when we did the Trivandrum Heart Failure Registry, 1,200 patients 5 years back, and today this data is available published in almost every leading journal. What we have learned is a couple of things. Number one, when we analyze the 5-year mortality, it is still 50%, right? Despite all these new drugs, it's still bad. But even worse, what we learned is this. In Kerala, we claim that we are all, Dr. Satish, my good friend is here, we say that we are all practice evidence-based medicine. Kerala is on the top of a health sector, right? Our infant mortality rate is what? 4.3. But then we found that only 24% of our patients at discharge go home on GDMT, guideline-directed medical therapy. 24%. 76% don't, right? And there's a hitch there. And what was the GDMT at that point of time when we started the trial, the registry? It was not this fancy 4, right? It was just an ACE inhibitor, a beta blocker, and an MRA, right? So even these 3 basic drugs, we are not giving it to majority of patients at discharge. And we also found that the hazard ratio of beta blocker at discharge determining 5-year mortality was 0.45, meaning that there's more than 50% reduction of 5-year mortality if your resident had written a beta blocker in the discharge prescription. So it's very important that we learn not just the basics, but what is new. And in that background, we just had the ESC Heart Failure Congress in Lisbon just last week. And today you have experts who will be presenting to you the data that has come out of it, the collated data, the filtered data, so that you can just learn straight away, number one. And the second part of the lecture is how best to choose an ARNI. We have huge array of ARNI brands today available in the market, right? From umpteen number of companies. Are they all same? Sometimes we find that our ARNI is not working. Is it because that we have not chosen rightly? The second topic would be presented by Dr. Pramod. First topic obviously would be presented by Dr. Subhash Chandra. So with that, I invite Dr. Subhash Chandra to deliver his talk on what we have taken home from the ESC Congress, Heart Failure Congress 2024 from Lisbon. Dr. Subhash Chandra.
Right, Dr. Tiny, thanks for those introductory words. I think it virtually summarizes what is going to come up in the next 1 hour's heated discussion. And I can assure the attendees that it is going to be a very, very useful program because it is happening right after the Lisbon meeting on heart failure from European Congress. So my task is just to apprise you about the backgrounds and the latest developments which have happened in this Congress. These are some of the contents which we'll be discussing. That updated treatment of HFpEF. HFrEF has extensively found molecules in the four foundational pillars, but a lot of research is happening on the HFpEF area. So that is to be discussed here. The misconception about the stable patients in heart failure, where the delay in instituting therapies lies, is to be discussed here. The HFrEF management, and how do we navigate and how to escalate the dosage so as to accrue the maximum benefit for heart failure patients in terms of reducing heart failure hospitalizations and mortality. And then in the end, we would touch upon a few small trials, which could be an observational or registry data as enlisted here. So let us see that what new has happened on HFpEF. Now, HFpEF, as we know, is an entity where the different systems of the body are concentrating on the heart so as to cause the preserved ejection fraction heart failure. It's a heterogeneous disease as opposed to the HFrEF, where heart is the main culprit and the rest of the body systems suffer. Here, we got to know that this is called as diastolic dysfunction of the heart. And in that entity, we had amyloid disease, we had hypertrophic cardiomyopathy earlier. But the focus now is going to be hitting on the individual components of the morbidity which are leading to HFpEF. So dedicated trials in individuals with HFpEF phenotypes is the theme of this Congress, where various therapies are tested in different etiologies of HFpEF. So that is one change. SGLT, of course, have emerged as the only molecule for the management of HFpEF, where it's class 1A indication in the European guidelines. Now, Americans, I think, is still inching up, where it is class 2B or 2A. We got to see that. Now, this chart summarizes everything about HFpEF, where the comorbidities like obesity, metabolic syndrome, hypertension, obstructive sleep apnea, diabetes, CKD, inactivity, COPD, iron deficiency are the ones which lead to the heart failure preserved ejection fraction. And this is a busy slide which touches upon the pathophysiology of HFpEF, whereas all these aspects have to be looked at. And in that process, in future, there are trials of IL-6, interleukin-6 in HFpEF area, and we look forward to having their results in future. These are all novel therapies. One has to wait. The CANTOS trial, where IL-1B inhibition was tested in few patients. And then, of course, in future, there are trials of newer drugs like ziltivekimab in Hermes trial and the Endeavor trial, which is another novel molecule. And these molecules are taken from this busy chart, which are responsible for the pathophysiology of HFpEF. The misconception about a stable patient, you would realize that in Paradigm HF trial, which was an ARNI's landmark trial, the majority of patients who were in class 2 and 3 and maintained systolic blood pressure and anti-BMP2 were not in a very high range, were called as all stable patients. And it was in this population that by giving ARNI as against enalapril led to the benefit in mortality and heart failure hospitalizations. But you would realize here that this is the stable population of heart failure patient, where we have an inertia of instituting drugs, who suffer most because of sudden cardiac death. The terminal deaths because of non-sudden cardiac deaths are happening in very advanced heart failure class 4 or so, but the very stable patients are the one who suffer from sudden cardiac death. And it is in this population that the indications of AICD or CRTD were much more pronounced, as well as the usage of drug in this population. So that myth has to be busted, that the stable looking patients are not truly stable. These are the patients who suffer most of sudden cardiac death, and they'll be benefited most if you institute the heart failure therapies of 4 foundational pillars in time. So there has been a change in level of evidence when it comes to the ACE inhibitors, and then going to beta blocker, the MRAs, the SGLT2 inhibitors, and of course ARNI as against ACE inhibitor would always occupy a very important seat as class 1B indication management. In the randomized data, the heart failure hospitalizations were reduced by 21%, mortality was reduced by 20%. But if you look at the real world data on this molecule, it is humongous that heart failure hospitalizations are almost double the reduction compared to the randomized data. And similarly for CV death and all-cause mortality. So real-world data goes in tandem, and it helps you to convince that the molecule is really robust in terms of reducing mortality. Supporting GDMT, as Dr. Tiny Nair pointed out in the beginning, the GDMT usage has to be escalated, and we got to be actively, proactively treating heart failure patients, where if you see in this, the up titration, early discontinuation are the factors instituted in this, studied in this study, and it is seen that the figure of discontinuation or lack of up titration is pretty high across the four foundational molecules as seen in this slide. And this leads to almost 50% of heart failure patients not being benefited of the therapies which are very well established in their management. So the real world data in Italy has said that almost 50% patients are not receiving the desired DDMT in these cases, let alone escalating these drugs to the optimum dosage. There are trials on ARNI on various aspects, including remodeling, the NT-proBNP reduction, and so forth, and symptomatology. And it clearly shows that all these parameters, be it remodeling or reduction of NT-proBNP or symptom improvement or heart failure hospitalization reduction or mortality, go hand in hand. And there are enough proof of the mechanism of this molecule in various trials which have come in past 5 or 6 years time to us. There were trials which have convinced us that even acutely sick patients who have suffered with ADHF are being fit to be discharged from ICU should be instituted GDMT at the earliest, and that leads to an early benefit in mortality reduction also. Adherence to ARNI because of hypotension or hyperkalemia is one concern, and there's an art of managing those aspects, and one can always prevail in terms of escalating these therapies in a graded manner, given the perseverance and instituting molecules like SGLT or beta blocker at the top, and then going to the horizontality where all the four molecules could be instituted right at the word go. So these were some of the conclusions taken from those important trials on ARNI, starting from Paradigm HF to Prove HF to various and so forth. Now, profiling of heart failure patients is very important, and this is very, very important for especially patients who have midref or the HFpEF. And based on these comorbidities and the etiology of HFpEF, one has to hit at those morbidities and treat them before embarking on treating the heart failure or symptoms of these patients. And in that process, you would realize that the blood pressure, the COPD, the cachexia, the atrial fibrillation, pulmonary hypertension, iron deficiency, and diabetes, obstructive sleep apnea, obesity, chronotropic incompetence, need for pacemaker, and coronary artery disease, which is very important etiology of HFpEF. All of them have to be kept in mind, and then you should tailor-make therapies when it comes to treating HFpEF patients rather than treating them as one entity. And these are some of the major comorbidities outlined here, which lead to the HFpEF. And it is here that the diuretics for symptom improvement and dapagliflozin, empagliflozin for overall heart failure hospitalization reduction emerge as the clear winner as class 1A indication. And of course, iron deficiency could be treated by injectable iron, atrial fibrillation, diabetes, hypertension, obesity, COPD. All of them have to be treated as the comorbidities of HFpEF. There are real-world data in that area, both in HFrEF and HFpEF, and it is seen that the minimal initiation titration of GDMT during hospitalization in US and Canada is also quite substantial, let alone in our own country. And this is a data taken from the Victoria Registry, where Veresogot eligible patients were looked at, and the GDMT penetration was not up to the mark as desired. So there are strategies for improving GDMT implementation, and Prompt HF is one electronic nudging where one can look at various aspects of HFrEF patient, dedicated heart failure clinics, and then this process can really help you optimize GDMT in majority of patients and escalate their doses from time to time as much as the hemodynamics permit. Beyond that, there were certain solutions for implementing GDMT. I won't go much in detail because these are all small trials. The Implement HF is one of them. Then trials like the Penta HF, where the inclusion of levosimendan before instituting 4 foundational pillars would come handy in terms of stabilizing these patients and reducing the heart failure hospitalization. So that is one small data which is presented here in Penta 5. and then trials like TEAM-HF, where again implementation study of accelerated heart failure GDMT in general cardiology clinic could be a way to go if you rely upon um, that app or the process of looking at various aspects of these heart failure patients' hemodynamics would help you. And then titrate HF study, where one has to look at the dosage given and the impact on hemodynamics and potassium and renal parameters of these patients. That would help. Chronic versus worsening heart failure distinction is very important, especially when it comes to the addition of fifth pillar, that is very got in these patients. And that's the way to go. Endorse HF is another small trial in a small number of patients on SGLT inhibitors. And SGLT inhibitors have clearly emerged a winner, where it can help you reduce the dose of diuretics required for symptom improvement, and of course, the mortality reduction and reduction of heart failure hospitalization in both HFrEF and HFpEF population. With that, I submit, and I'll give it back to Dr. Tiny Nair, who can take it further from here. Thank you, sir.
Thank you, Dr. Suvarshan. That was an excellent summary in 15 minutes of something that ran for 4 days and had so much of complexity. I think you made the points very clear as to the way HFrEF treatment is going, the way HFpEF is going, the way HFpEF is far more, the spectrum is far beyond what meets the eye, and how difficult it is to treat, and the comorbidities and the spectrum. We'll all come back in the discussions. And if the attendees, do you have any questions, please write it down and type it out so that we can take the questions and ask our esteemed panelists as to what is their opinion about it. So now we move on to something that we were initially talking about, and that is how to choose the huge number of ARNIs available in the market. Are they all same, or is it important that we choose carefully, or is there a science behind it? And to talk to us, we have Dr. Pramod with us. Dr. Pramod, please take up your topic.
Thank you, Dr. Tini Nair, for giving me this opportunity. And as you said, the Trivandrum registry is one of the landmark registries which has given a lot of insights about Indian subset of patients with heart failure, and a lot of things are to be learned from that. Though we discuss in fora that we are not using the GDMT to the expected levels, but I think some inertia is always there, and I think overcoming that inertia is very important, because the benefits of these drugs are overwhelming in decreasing the mortality, especially in heart failure patients. So how to choose the right ARNI? Because now we are flooded with so many drugs in the market, and many companies manufacture, some of them are locally also manufactured. Whether we have to go with them, or how to choose the right ARNI in which kind of patient, that is what we are going to discuss briefly now. So as already mentioned, 9 out of 10 patients with the heart failure are symptomatic, even with current therapies. And each hospitalization for heart failure increases the risk of mortality further. If you look at the mean survival after the first hospitalization, it is 2.6. But as the time goes on with the second, third, and fourth, the mean survival decreases to 1.3. And in this, it is very important to also note that the time duration between the recurrent hospitalization becomes narrower and narrower. That is also very important. And therefore, the most important and paramount thing is to prevent the first hospitalization for heart failure. And there is a tremendous evidence which supports the first hospitalization can be delayed in these patients. We may not totally prevent it, but at least we can delay and give the patients a good quality of life for the time which they live. And the prevalence of heart failure is increasing. Actually, about 10 million patients are there now with heart failure in our country, and it's about 1% of the adult population. And post-admission mortality is very high. It is 20 to 30%. And also, we know that half of them are dead by the end of 5 years. And one important thing when compared to Western population is that our Indian population are relatively young people. And therefore, it's all the more important to focus on them, because we don't want them to die young. And incidence of diabetes is also high. As we know, it is more than 50%, and hypertension is about 42% in our country. And medication adherence ranges from about 25% to 50%. And this is also one of the important points to be highlighted always. And there is a good data from our National Heart Failure Registry, again pioneered by a Trivandrum group of doctors. And it is conducted in about 53 centers in 21 states in our country. about 1,000 patients data. And most important and the significant etiological factor was ischemic cardiomyopathy, about 70%, I think, and about 25% were dilated cardiomyopathies, remaining contributed by rheumatic heart disease, etc. And in these patients, it was observed that the GDMT was only 47.5%. So guideline-directed medical therapy was given only in 47.5%. That is less than 50%. And the death rates were very high. Actually, the 90-day mortality was the published information from this registry, and it is 14.2%. And it tried to bridge the gap with the representation from diverse geographical areas across India, north, east, south, west, all together. So it reported one of the two eligible heart failure patients failed to receive the GDMT, and we can see here the various usage of drugs, the standard drugs, which at the time were beta blockers, AC inhibitors, RB, or MRAs, and ARNI. We can see ARNI was just coming at the time. This published data is 2022, not very old. ARNI was already there almost about 8 years. And very dismal usage of ARNI can be seen, maybe because of pricing, also one of the important factors that impacted the usage of ARNI in this data. And guideline-directed medical therapy is actually the foundation of heart failure care. And it is coming with the highest expected benefit, and it should be really prioritized. And we have to keep reminding our physicians and colleagues about this. And as already highlighted by Subhash Chandra, the latest guidelines also emphasize, and ARNI is recommended as a first-line therapy for heart failure with reduced ejection fraction patients by both ACC and also the latest ESC guidelines we have heard. In patients with chronic symptomatic HFrEF, treatment with ARNI instead of ACE provides a high economic value, and SGLT2 therapy provides intermediate economic value. But I think during the discussion, we can see whether usage of both these drugs can be having an additional benefit, because each hospitalization incurs a tremendous expense, especially in our country, because the patient pays out of pocket, and therefore it is always prudent to prevent the hospitalization for heart failure. And as I've already mentioned, as my earlier speakers and Dr. Tini Nair also mentioned, usage of ARNI is very dismal in this Trivandrum registry. It is less than 4% in the Indian heart failure patients across the spectrum. At the time, I think HFpEF, there was no strong indication, but now we can discuss about the usage of ARNI in HFpEF. Dr. Subhash already mentioned some data that has come up in the recent ESC 2024 in the Lisbon. And if you look at the different spectrum of heart failure where we can place the sacubitril valsartan, it can be used in chronic HFrEF patients, and then patients who are hospitalized for HFrEF, and also people who are admitted with de novo heart failure or newly diagnosed heart failure patients, and also in patients with diabetes. And lastly, I think we can add a little bit about the heart failure with preserved ejection fraction, which also is seen like something like a tip of the iceberg. There are a lot of people who don't know that they have HFpEF unless we clinically do some echocardiographic examinations and various parameters. We look at it and also use NT-proBNP to make a diagnosis. Many of them think that their shortness of breath is contributed to by other factors like anemia or respiratory, overweight, all those things. But definitely underlying HFpEF is one of the important things, and the prognosis is equally bad for HFpEF as with the HFrEF. So firstly, the data about chronic HFrEF patients. I think paradigm HF, which was alluded to by Dr. Subhash Chandra, is the game changer in the management of heart failure with reduced ejection fraction. Till the time, we were mainly banking on AC inhibitors, especially we were using enalapril, then ramipril. All these things were used for heart failure. And this trial really was showing an additional benefit of 20% reduction when compared to enalapril in patients with heart failure and reduced ejection fraction. It is about 8,000 patients study, which has shown that primary composite endpoint of death and heart failure for hospitalization, 20% reduction was shown. And CV death, which is also one of the hard endpoints which we look at any therapy, 20% reduction. And then heart failure hospitalization, about 21% reduction was shown with sacubitril valsartan when used in the maximum dose of 200 milligram twice daily, as compared to enalapril 10 milligram twice daily. So this is really a game-changing trial for the ARNI, and it has become established as a therapy. And also the current guidelines recommend replacement of ACE inhibitor or ARB for ARNI in people with HFrEF. And also, what about the Indian sub-study of paradigm, whether our subset of patients compare the beneficial aspects to the Western? That was published by Jain et al. And in the trial paradigm, there were 637 Indian patients. So 322 were randomized to sacubitril valsartan and 315 to enalapril. And the composite endpoint was similar in Indian and global as well. And p-value for interaction was 0.5 in this heterogeneity study. And cardiovascular death, again, it was similar. And all-cause death was also almost similar when compared to global. And definitely our patients, though there are some demographic differences when compared to the Western population, like our body mass index is less, the incidence of diabetes is more, and our people are younger, even then the benefits were definitely on par with the global results. And next, we look at the people who are hospitalized for heart failure and reduced ejection fraction. This is a Pioneer HF trial, which has looked at the sacubitril valsartan initiation. And this was a good study because it initially looked at reduction in the NT-proBNP levels and also the clinical benefits of sacubitril valsartan in people who were treated from the acute admissions. They were taken up to 24 hours to 10 days. And then at 8 weeks post-discharge, the benefit was definitely there in these people also. Cumulative incidence of serious composite endpoints was lower and when in sacubitril valsartan when compared to enalapril. There was a 42% reduction of CV death or rehospitalization with sacubitril valsartan compared with enalapril in this study. At the same
connectivity issue, we'll just wait for 2 seconds.
Are we getting Dr. Pramod back or?
Yeah, we are trying, sir. We are
Meanwhile, Dr. Kamal, we can utilize this time for discussing.
Yes.
I think, yeah, we can,
Sir, yeah.
yeah, we can utilize this time, by the time when he connects, we can go back to.
Sure.
Dr. Subhash, it was very nice listening to your analysis. What is your, your thought of on ARNI in HFpEF, are you actually looking at it that maybe in the couple of years' time, we would have a combination of SGLT inhibitors plus ARNI coming in? Or do you think that still because of the head start data of SGLT very clearly showing benefit, it still would be leading the, in HFpEF, I'm not talking about HFrEF here.
Dr. Aini, if I talk of ARNI in HFpEF domain, we must appreciate that trials like Paragon or Paradise have shown us some hope. It was just that by virtue of the design of trial or the failure to meet the endpoints, adequate endpoints, that led to perception that this molecule is not effective at all, which is not the case with SGLT inhibitor. They were robustly found to be very efficacious. But I personally feel that there's a hope. And in HFpEF, nobody prevents you from giving any drug, be it a beta blocker or an ARB or an MRA. All these molecules have had trials in HFpEF, and you're free to use them depending on what kind of comorbidity you're dealing with. So I find that ARNI still should have a place in managing HFpEF in tandem with diuretics and SGLT2 inhibitors. And of course, MRA, where the fine art trial on Finenon is coming up as one very important ray of hope. So we are just hoping that we should reach a point where ARNI could be a useful molecule even in managing HFpEF.
Yeah, Dr. Prashant, any take on that?
Yeah, Tiny sir, would ask Dr. Subhash or either you, HFpEF being a very heterogeneous entity, and if you dig deep into Paragon data, so there is a tendency to benefit between 50 to 60%, more so with women. So the higher ejection fraction, women behave like kind of on the lower side vis-a-vis men. Yeah. So we can see that 50 to 60% realm of HFpEF, there it could be kind of a class 2A drug rather than B drug or class 1B drug in HFpEF. And the ones who are having a HFpEF and a rejection fraction hovering below 62%, especially women. And a controversy erupting about, as Subhash sir said, about usage of beta blocker in HFpEF. Like the previous was the paradigm that heart rate should be below in order to have a good luciotropy. But now they said that heart rate should be higher in HFpEF patients. I was just attending last week in Best of AC session in Bombay. So would you elucidate throw some light on this, Tiny sir or Subhash sir?
Yeah, I think, see, it is very clear that HFpEF, as you said, is not a single disease like HFrEF. Okay, you can have that's why we are all talking about phenotyping. On one side, you can have somebody with a gross metabolic abnormality. Okay, he obese, diabetic, that is one HFpEF. Another, you will have an elderly, thin gentleman who has got AFib and huge left ventricular hypertrophy. Right. Then you will have one gentleman who will have CKD. And another person who will have gross right heart failure features. So these four that we normally see in clinical practice, I'm not talking about the other phenotype. So they're entirely different. And exactly like you said, the data shows that if we tease out that subset, women subset, very clearly benefit till that ejection fraction of 60 in benefit. So there are some people who would benefit, but like you said, we are unaware as to who it is. That is the real challenge. So we know that people who are very close to a recent heart failure episode and women, these are two subsets who tend to benefit even with the preservation fraction with ARNI. That's all. Dr. Subhash, any comments on that? I think our other panelists are also there. Please, you can switch on your camera.
I completely agree with that thought. And what Dr. Prashant had pointed out is very valid, that in a definite subset, women and EF up to 55% or so, there were benefits. Even on renal outcomes, there were benefits. So this molecule has a hope, and we just have to wait and watch.
Yeah. Do we have Dr. Dilip, Dr. Prashant, and Dr. Satish in here? I mean, you can just say your opinions on that. You're all very senior.
Tiny sir, Prashant,
sir,
again,
Dr. Pramod,
about the beta blocker controversy, just if you are in a HFpEF symposia, whether to use it or not to use it, or whether to decrease heart rate or not to decrease heart rate.
See, Dr. Prashant, you might remember that a couple of years back, there was a paper that patients of HFpEF with rapid heart rate benefit with beta blockade. But if you look at the recent data, you were talking about that ACC presentation. I was also in one of those. They very clearly show that in HFpEF, Now, if you withdraw beta blocker, their effort tolerance actually improves. Right?
Yeah.
Clearly, they have shown the data. And not just that, their long-term outcome don't worsen. So unless we are looking at somebody who had a very recent MI, where there is a very clear indication of beta blocker, or somebody who has an HFrEF, if it is an HFpEF patient, and if you see your HFpEF patient is over time worsening and on beta blockade, today the concept is that you can try reducing the beta blockade dose and see whether his effort tolerance improves. I mean, by withdrawing beta blocker, are we improving his survival? Are we reducing his heart failure hospitalization?
No,
We don't know.
yeah.
Are we reducing his sudden cardiac death? We don't know. Actually, see, if you look into sudden cardiac death, even with ARNI and SGLT inhibitor, sudden cardiac death is reduced, but beta blocker is the king, right? Nobody can beat a beta blocker in reduction of sudden cardiac
Absolutely.
death. If you look at the CBIS-2 data, we very clearly see that starting Concor early, we reduced it by 30% sudden cardiac death. Massive
Gee.
reduction. So beta blockers are good, but this recent concept has to be put into, but we don't want to confuse the listeners. Tomorrow, nobody should go and say that, oh, my heart failure patient can't walk much, I will withdraw beta blocker. That might be catastrophic. In a patient of HFpEF, where there is no clear indication of beta blockade, if your patient is on beta blockade and his effort tolerance is worsening, it may be worthwhile to slowly reduce it to see whether his symptoms improve. And that has been shown in the last 2 JSC publications, and we also
Yes.
heard the ACC
Yeah.
team talk about that.
Yeah, Nair sir,
Perfect, sir,
sorry to
perfect.
disturb. Dr. Pramod sir had joined, so can we
Yeah,
just start the
Pramod, if
presentation?
you can please, if
Yes,
you can.
yes. Sir, please. Sir.
So my apologies. I think my Wi-Fi got into trouble. And if you permit, I will continue and present the other slides.
Please,
Please,
please.
sir.
Okay. Are you able to see the slides?
Yes, sir. Yes.
So we have stopped here at the de novo heart failure patients. And definitely there is a role for sacubital valsartan in people with acute heart failure as well. And initiation of sacubital valsartan keeps hospitalized patients alive and longer. And we can see there is a 20% reduction with the sacubital valsartan in this group of patients. And there is a 46% reduction also in these people with the heart failure and hospitalization. And in diabetic patients also, there is a definite benefit. And we can see that CV death and HF hospitalization is definitely favored in diabetic people. This is from the paradigm subset. There is again same 20% reduction in the risk of CV death and hospitalization in these people, regardless of their glycemic control. And it improves the LVEF in HFrEF patients and in diabetic as well. So the same thing here, the A1C reduction is also shown to some extent with this. And about the heart failure and preserved ejection fraction, I think this is one of the important topics. And it is shown in 2 trials. The one is the Paramount trial, which showed there is a decrease in the NT-proBNP, which is a biomarker for the heart failure. And Paragon is actually the clinical trial, which showed there is a decrease in the HF hospitalization, CV death. But it was found especially in women with the ejection fraction up to 50 and 57%. So beyond that, in this subgroup of patients, there was no benefit. And targeting the sacubital valsartan for heart failure in mildly reduced or preserved ejection fraction, we can see the data that is presented here. And the Indian approval is there for the sacubital valsartan. And there are, as we mentioned, there are several drugs that are flooded once the patent went off. And we have to use the drug that has good bioavailability and proven efficacy. And one of the important points here I put in the bullet is that JB Pharma, which is hosting the current discussion, it imports the drug from the Novartis company, which is the innovator. And there are certain points which we have to know about the molecule. This is a complex in crystalline form having different properties from the physical mixture of 2 active compounds. As you know, sacubital and valsartan, these are the 2 molecules that are put into a unique salt formulation. There is a 1:1 molar ratio of both these drugs. And there is a supramolecular complex with unique physicochemical properties and good solubility profile. Enhanced bioavailability of valsartan is there with this. And drug bioavailability is made more by the co-crystalline formulation. And there are some important attributes also which are tested in comparison to other drugs. There is a comparative evaluation of different brands of sacubitril/valsartan for the presence of co-crystallization. And one is X-ray diffraction studies, which have shown that the molecule that is available from the original Novartis and also Azmarda is the same. And also there are other things like optical emission spectrometry that look for the sodium content, and the sodium content is similar to the original, whereas in other products it is twice more than that. And surfactants are also studied, and it was found that none of the product had the same innovative lattice as that of the Azmarda, to name the product. And as I mentioned, there are sodium content that is more in the other products. And here, the co-crystal complex is engineered with optimized sodium content to achieve better physical and chemical stability, hygroscopicity, and handling and storage. So dissolution also is important. It dissolves in acidic pH. The innovator product showed higher dissolution when compared to other products, especially now there are a lot of generics also available. I think we have to keep in mind the bioavailability of the drug is equally important, and these pharmacokinetic properties are very important when we choose the drug. So to sum up, I think sacubitril/valsartan developed by the innovator offers an unmatched legacy. There are more than, I think, 8 years of experience evaluated in 230 clinical trials, and more than 3 lakh patients are studied, more than 1,500 Indian patients as part of global clinical trials. And this is the original and imported molecule that is available for us. And I think price is also comparatively cheaper. And future lies with ARNI. That is my concluding slide. In ACS, hypertension, and also in other all indications in heart failure, etc. It is one of the important drugs that is available and useful now. Thank you very much. Thank you for giving me this opportunity and bearing with the interruption.
Thank you, Dr. Pramod. That was excellent. Enjoyed your talk. I think we have gone quite late in our discussion, but I think before we can we request our panelists all to join, please, because we have heard Dr. Subhash talking, we have heard Dr. Pramod's excellent talk, we have Dr. Prashant had interacted so much. We have not heard from Dr. Dilip and Dr. Satish. Are they there connected? And if so, I saw Dr. Satish connecting. Dr. Satish is my close friend. We work in the same city. He is one of the most prolific, most academic nephrologist I know of. Dr. Satish, what would be, we start with you because we have not heard your opinion. What would be your take on ARNI, sacubitril/valsartan, in patients of heart failure with CKD? Because this is a common question, right? Today we know that most of our heart failure patients will have a little bit of reduction of GFR or maybe even a gross CKD, right? And it's so difficult to treat them because the first question that the physician asks or our resident asks is that below how much of GFR is ARNI contraindicated, right? And in fact, the real challenges of ARNI, this excellent drug, is just 3. 1, hypotension, 2nd, hyperkalemia, and 3rd, low GFR. So people are stuck there. GFR of 40, 30, should I give, I will not give, so the patient doesn't get that benefit. So would you please tell us your opinion, because we value it so much. Dr. Satish.
Yes, thank you, Dr. Taini, and very nice discussions, all of them, and lovely talks also. I'm really glad to be part of this forum. So about CKD, I think if you look at that, CKD patients are generally discriminated against. They are not part of clinical trials. If you study any new drug, they will exclude CKD patients. If you study any new methodology, exclude CKD patients. Even primary angioplasty was not given to CKD patients for such a long time because they say creatinine is high and then you don't want to do a primary, kidney will become worse, etc. And some patients also go overboard. They say my creatinine rise, I don't want anything to do with so it's more important then. So it becomes a problem. But I think if you look at it, you should consider CKD as part of general population. If a patient has FRF and has CKD, that patient should be on ARNI. So I generally take over because whenever the cardiologist comes to the refers the patient a creatinine of 2, if they have not started on ARNI, I start on ARNI and I follow up with the cardiologist also. We follow up together. So the problem is, of course, hyperkalemia. The hyperkalemia is actually generally less with ARNI than if you give, say, enalapril or ARBs. So if you're giving telmisartan or something like that, and the hyperkalemia is actually more with that. So ARNI is actually better in terms of hyperkalemia considering, compared to its other equivalents. And the thing is that patients with CKD, actually, I find they benefit much more than other. I've seen some miraculous recoveries in patients with CKD. Their recurrent admissions, pulmonedema, you start them on ARNI and it's like magic. The entire thing vanishes. They become completely fine, they're settled in. And a patient who was on recurrent admissions for 6 months has now been following 4 to 5 years without any problem. Their creatinine, which was going up every time, they started from 2.5, gone up 3, 4, 5, etc., has now come back down to 2.5 to 3 and is remaining stable. So kidney function also stabilizes with ARNI. So you must understand that initially it may go up. The only thing is that probably we should have a discussion with a nephrologist, and in combination with nephrology and cardiology, we should sit together and treat the patient. That's the only way to do it. But definitely the benefits are there, and not only that, we have got a new study from Trivandrum itself, studying the use of ARNI in dialysis patients. And we have shown that patients who have some urine output, of course, if they have no urine output at all, sacubitril, I don't think it is going to be of any effect. But in those patients with dialysis and who have residual renal function, definitely there is a benefit with ARNI in those populations also. So even up to dialysis, we can continue. There is no subset of CKD that you cannot give ARNI.
Excellent, excellent. I think that fully agree with that. That ARNIs are not just that. It is those patients who tend to develop dips like hypotension initially or
Yeah.
dips in GFR initially are the one who are going to benefit maximal in the later part. And they
Definitely.
don't have more events. They have clearly shown that the dippers don't have more events. So don't be afraid that, oh, my patient blood pressure was 110. I started ARNI, now it is 95. I mean, that is the patient who would eventually pick up, and exactly like Dr. Satish said, that why come and thank us with their life that he has become so much better and all that. So I think ARNI is an integral part, and even when the same thing was said for SGLT also, that okay, the GFR is so low, how is SGLT going to act? We are not looking at mere reduction or improvement of kidney function. We are talking about, see, the kidney patients all die of heart, right? They have a MACE or a heart failure hospitalization or die of heart, right? And that would be prevented by ARNI and SGLT inhibitors. So I think it's an integral part. Thank you, Dr. Satish, for elaborating on that. Do we have Dr. Dilip connected?
Sir, no, some emergency, so he is not there.
Okay. Okay. So do we have questions? Anything from the attendees?
Yeah, sir, one question from the attendee is about the Dr. Pramod Kumar sir showed about the co-crystalline technology which is there in the ARNI, in the innovator Azmarda. And so can you just focus more on this, what's it's important in a clinical patient? So can you please share your views?
Yeah. Dr. Pramod?
Muted.
Yeah.
Sir, you are muted. Dr. Pramod, you are on mute.
As I mentioned, it is a combination of two molecules, that is sacubitril and valsartan, in a equimolar ratio, 1:1. And when you combine both these things, there is a co-crystallization, and there are certain properties that are very important when you use this combined crystal. And they have to be studied by X-ray and other molecular features. And if they are satisfied, I think the benefit will be equal to the molecule that is given by the originator. And this compound, because it is purchased from other sources, it may not fulfill these criteria. And therefore, a original molecule is important to get the complete benefit of the molecule, of the drug.
Yeah. Thanks.
Let me add up a little bit on that. See, the point is that this is not very clearly, this is not an advertisement of any brand, including Azmarda. We are not talking about that. All we want to impress upon you is that in this particular medication, ARNI, it is extremely important as to how it is manufactured. I will tell you the reason why. See, years back, we had multiple NEP inhibitors, like omapatilat, we had candoxatril, we had ecodatril, we had acetorphan. But theoretically, yes, they all increase BNP, CNP, ANP, bradykinin, adrenomedulin, but there was no benefit in mortality or reduction of cardiovascular events. And that is the time when we learned that if we block NEP, these NEP inhibitors increase angiotensin II. So you'd get benefit only when you supply an optimal amount of angiotensin II inhibitor like an ARB piggybacked on a NEP inhibitor like your sacubitril. So then initially we all asked that why don't you have 2 pills, one of sacubitril, one of valsartan, and eat it. It doesn't work. So it is a very complex lattice of co-crystallization that seems to work. And all that Dr. Pramod has shown is that not everything is similar. So you need to choose carefully, right? So it is exactly like low molecular weight heparin or a biological product, where unlike a tablet of paracetamol, whichever company you buy, this may not have similar efficacy as you expect. So be careful when you choose a brand. That is all about it. Because each one seems to be, see, this is beyond the purview of a physician. We have very little knowledge about how Dr. Komal is involved in manufacturing. But it looks like each one is different. I mean, that is take home just that. Each one is different. And so if one is different from the other, maybe their actions and their event rate reduction might be different. That's all about it. Any other questions coming in?
Yeah, thanks, sir. So next question is about how to maximize the dosage of ARNI in clinical practice. We feel it difficult to go to 200 mg. So your suggestions on that. So anyone can.
I think anyone can. Dr. Subhash Chandra, Dr. Pramod, Dr. Prashant. Anyone?
General,
Yes, sir. So in my practice, I try to maximize so I say that the maximum dose of ARNI is the maximum benefits equivalent to. Otherwise, maximum tolerated dose of ARNI is the alternative. And at times, patient comes with 88 systolic blood pressure, 90 all, and it coming walking. And then there are so many offline thing. I do 50 mg, half Azmada, half BD, or something like that. So many tips and tricks. But I strive to endeavor to put to 200 BD, the guideline directed dose, many of my patients, but which is always, and there are so many, you have to remove diuretics, you have to remove a non-essential drug, nitrates and other antihypertensive and CCBs, and so many tips and tricks. And you have to be good erudite internist in order to risk assess and dynamically triage the thing in order to accommodate these disease modifying drugs in. And so you have the right question. You have to ask to be on the highest dose, but it's not always possible. Tiny sir, Subhash sir.
See, I think, this is basically our inertia, which is again understandable. See, let's say a patient, all of us have started on ARNI, so let us say 50 milligram twice a day. Okay, and he was ill in the ICU and all that. Over time he has improved. We have convinced him to take ARNI, and now he comes back for follow-up. How are you doing? Sir, I am doing excellent. I am going to school, taking class. I am a teacher. I am back to class. I am fine. Excellent. Thank you, sir, so much. Right. Now this patient, he is doing well. So normally, it is our inertia where we would say, okay, 50 he is fine. Why should I go and make it to 75 or 100? Right. Unlike a thyroxine, or we don't have an, okay, if he had shown us a BNP, and if I'd seen that his BNP is still 2,600, I would have said, no, there is something wrong, you increase it. Or if he had come with an echocardiogram which showed that previously EF was 45, this time it is 40, I am sure to increase the ARNI. But what happens most of the time is clinical common sense. He comes and says he's fine, everything is fine. And we don't feel like increase, but understand for every one of us, again, relearning that we should go to the guideline-directed medical therapy dose to get maximal benefit. But there's a small caveat. See, here, we should not feel shy that my patient is on 25 BID. JACC had published last year a cohort where, in a real-life data, it's 850 patients. They divided them into 3 groups on the dose of ARNI they were on. I think the lowest dose was 113 milligrams daily. Second dose was some 220, and third was about 400. And they showed that if you look at their ejection fraction, their end-systolic dimension, their end-systolic volume, and their NT-proBNP, everything reduction degree was same, 20%. So not that is not to tell us that don't go to maximal doses. Do go to maximal doses to get the full benefit. But at the same time, even if you have given a small dose, don't be shy to admit it, because even that would have done good to your patient. Dr. Subhash, any comments?
Yes, sir. I completely agree with both the views. And in Indian practice, we have seen, though we don't have access to 25 milligram tablet, yet in patients who have very precarious blood pressure levels, we do give breaking these tablets into half morning and half evening. And believe me that if they tolerate this dose, the patients come to a level where they could even tolerate 50 mg, and then from there on, we can escalate it to 100. But we should strive hard, as you rightly said, there should not be inertia in escalating the dosage. We should strive hard to give them 200 BD. And if I share my experience, maybe 40% of my heart failure patients, HFrEF patients, are tolerating 200 twice a day tablet, and another 30% would be tolerating about 50 BD, and rest are on 100 BD. That could be the split of the patient which I see. And keeping a close watch on the potassium levels, because sometimes these patients have cardiorenal syndrome, and of course blood pressure levels. We should try to escalate all the 4 foundational pillars. In SGLT, the best part is that you just one dose and you're done with it with very robust benefit. And of course, MRA along with ARNI, one has to be cautious looking at renal functions and the potassium values.
So next question, up to what creatinine level should I start ARNI in my patients? Creatinine, potassium, and the EGFR. That's the question.
Dr. Satish, should you take it up?
Yeah, definitely.
Already.
Yeah, so already I think I partly answered that question. So there is no level of creatinine at which we would not start ARNI in any patient with HFrEF. Definitely there. Potassium is a different story. So generally what we do is if the potassium is high, I mean 5.5 is my cutoff for saying high. 5.1, 5.2, I'm not really bothered. So if it is more than 5.5, probably we will try all measures to reduce the potassium. Say put him on Lasix or something like that, put him on a low potassium diet and all that. I don't usually use the potassium binders that much because they are difficult to tolerate and they have a lot of toxicities and they're not very effective. There are newer potassium binders which are not yet available in our country, which may change this. But right now, our potassium binders are not very good. So it is not good for long-term use. Short-term use, it is fine. For long-term, it's not good. So that is the way I would do. So if the potassium is very high, then probably I would not be starting the ARNI because it's too dangerous. But if the potassium is up to 5.5, I will start and I will follow up and take all measures to reduce the potassium. So that's the answer to that question.
But I think as the newer potassium binders come in, probably the whole scenario would change. Because in US,
Definitely.
I was talking to a few cardiologists, their standard protocol is that they put the patient on
Yes.
a potassium binder like Localma, and then add up Fenolone and add up sacubitril valsartan and everything kind of thing. They say, oh, nothing will happen, and they tolerate it so well. So preemptively you add
There
up.
is data. There is now data that those people who are not tolerating ARBs, especially in CKD, and in those who are not tolerating ARNI in heart failure, you add this potassium binder, and they have their mortality improves because you are adding this molecule, which is definitely effective for them. So that will definitely change the practice. Only problem is that when these come here again, the cost will be prohibitive in the initial stages. So that's probably one of the reasons why ARNI take-up is also not so great.
So aren't SGLT2 inhibitors are RAS inhibition facilitators? Like if we have SGLT2 inhibitors on board, so this is a realm where I think RAS inhibition or MRA to some extent are accommodated well, because their tendency to blunt the downhill trajectory is more vis-a-vis SGLT2. Of course, they all are are hard outcome improvers. So SGLT2 inhibitors on board, and then we have a good leeway to accommodate, make them go inside and have a good commodiousness. Is this a tip and trick?
There was a paper in JACC which showed that with SGLT on board, your chance of achieving a better dosage and patient tolerating an ARNI and an MRA is far better when SGLT is on board. That is well known. The chance of hyperkalemia would be less, perhaps.
Lesser, yeah.
Add to that, there is some data also showing that SGLT2 inhibitors will also mitigate the potassium rise.
Yes,
so it may be useful that way also.
Yes.
So it's a good, sir, Dr. Satish, sir, that you are saying at any level of EGFR, or so you said that you went to stage 5 ESRD or stage 4 is no hindrance here. But unfortunately, I should be saying in a very harsh words, many nephrologists are still very fearful. We somehow build up and they stop at EGFR 30, 35, scaring patient, and they're not aware there's something called heart exists up there. So this is and good that it's coming from you as a nephrologist and all Dr. Tiny, Sir Subhash, are all super QS of India whom we follow. This is very important. If all the people are the delegates, eminent people who are listening, this is very important.
One important addition, which I think should have come from Dr. Satish, who's a nephrologist, is that one has to go deep into taking history that what kind of salt are these patients consuming. So a lot of these patients, in order to reduce their sodium content, would resort to taking Senda namak, kala namak, and all those kind of low na and low salt things. And that is a big culprit in causing hyperkalemia also, besides having these drugs on board. And of course, consuming a lot of fruits or juicy items or coconut water, banana, all of this could lead to hyperkalemia, which should be striked out from their diet. And of course, looking at all the aspects. The second aspect is that between the ACE inhibitor hyperkalemia and ARNI hyperkalemia, I think ARNI hyperkalemia is much less lethal as compared to the others. And SGLT, of course, on board does some trick to let it be tolerated well. So that is how we manage the potassium story.
G.
So next question, can I take? It's about
Yeah, I
the
think last question. We can take the last
question.
one.
Yeah, I'll take the last one, sir. This is regarding diagnosis of HF, especially HFpEF, where how your tips on early diagnosis, because where these people miss. So your tips, your insights on this diagnosis part.
Yeah, Dr. Satish, Dr. Subhash, you want to take it?
Yes, sir. So diagnosing HFpEF is an art. One has to take history that any obese person presenting with dyspnea whose echo LV ejection fraction seems normal, and you don't find a pulmonary cause, one has to order an anti-proBNP and ask your echocardiographer to comprehensively conduct the diastolic function of these patients. And that is how we arrive at a diagnosis. Besides this, there have been a lot of pointer systems where HFpEF pointers could give you the score and one can easily diagnose it. There'll be rare instances one has to resort to doing invasive studies in these patients where one can measure pulmonary artery pressure or the exercise hemodynamics in cath lab. And all those have been enlisted when it comes to diagnosing HFpEF, but one needs to really strive hard to diagnose HFpEF before instituting these therapies.
Oh, perfect. Perfect.
Yeah. So now I request Nair sir to please give the concluding remark.
So thank you, everyone. I think we had a fantastic learning session. First of all, we learned about the breaking news from ESC, and where we clearly learned a couple of things. Dr. Subhash Chandra taught us that number one, in HFrEF, ARNI rules. Yeah, ARNI is the best in HFrEF, and it forms clearly a part of the 4 foundational therapies, and you have to institute ARNI. You have to be careful that you are going to the highest possible tolerated dose to get the maximum benefit, in addition to the other 3 of SGLT inhibitor, MRA, and beta blockade. That is point number 1. Second thing is clearly showed that the data coming out shows that there is no stable heart failure, right? Any heart failure patient, see, understand that a heart failure patient who is in class 1 has the highest risk of sudden cardiac death, right? So there is no stable HFrEF. Anytime he gets one hospitalization, his situation worsens and the downslope goes far more steeper. And the third thing he taught us about the upcoming concepts of HFpEF, whereby there are so many phenotypes. There could be an obese, metabolic, abnormal person. There could be a thin, elderly gentleman with AF. There will be somebody with a CKD, or there could be somebody who has a very severe LVH, like an HCM variant. So, it's a different phenotype, and we need to choose carefully as to how we apply our therapy. Dr. Pramod very carefully and very nicely showed the burden of heart failure in India. The Kerala Heart Failure Registry, the Indian registries, and how important it is to treat them properly. And he also showed that how the available brands, how they vary in the market, right? Their co-crystallization techniques probably is so different that each one shows different characters. So they are not same. So we need to choose carefully. And, in the question and answer session, we learned a lot of things. We learned that, and again, let us re-emphasize that what Dr. Satish said, that any GFR, don't refuse the patient or don't deny the patient the improvement that he might get out of ARNI for his heart failure, right? So even if his GFR is low, he's on dialysis. Like he said, the paper shows that ARNI, they tend to benefit. How they benefit? By reduction of cardiac event, not the kidney, which has already been fried up. So that is not the point. So I think we had a fantastic discussion. We learned a lot. And thank you, Dr. Komal, for organizing this. Thanks, JB Chemical, for bringing everyone on board. And with that, good night. And maybe Dr. Komal will arrange for such symposium shortly, and we can interact and see each other sometimes. Thank you.
Yeah, thanks,
Thank
sir.
you.
So on behalf of JB Pharma, I would like to thank all the esteemed panelists for sharing your expert insights on this complex subject of heart failure management. Thank you all. These are very helpful for all the physicians for managing HF in day-to-day life. Thank you, sir. Thanks a
Thank you.
lot. All the
Bye,
best.
Tiny sir. Bye. Bye.